morning, India. Good morning, Nepal. A big thank you to Nepal for participating in this conference and collaborating with us. Today, I'm going to speak essentially on a pediatric cox spine. What are the difficulties in that? And what are the options we have? Pediatric cox spine is not same as an adult spine. A lot of differences are there. So let us find out how the pediatric vertebral column differs from the adult. Our pediatric spine is immature and more flexible. The bodies are essentially cartilaginous, especially in the younger children. Spinal ligament and the facet joint capsule are more stretchable without any tearing. Paraspinal muscles are relatively weaker and the facet joints are more shallow and horizontal. Vertebral column essentially begins being cartilaginous. Destruction in a cox spine is very rapid in the children, and so they develop a kyphotic deformity. But when it is diagnosed early, conservative treatment gives the excellent result. So what kind of conservative treatment we give? Whether TB without any neural deficit or whether early deficit, a non-surgical treatment works very well. Two important things we need to do. One is the AKT and second is the bed rest or the bracing. Whenever you talk about the AKT, adult it is very easy. You can calculate and give the AKT. But in children, you have to be very particular because the major consideration what happens in a antituberculous treatment children are underdosing should not happen. One. Secondly, the modification of the drug doses as the child gains weight. That is equally important. Must give a appropriate formulation. And must remember that streptomycin and ethambutol are given with care, or they may cause a toxicity to the children. Surgical treatment is indicated in cases with the instability, which can be diagnosed by the spine at risk signs, or it can be because of the progressive neurological deficit. So two indications. One is instability, second is a neurologic deficit for which we need to go in for the surgical option. Now, what are the problems in the surgical treatment? In the children, bone being essentially cartilaginous, fixation may be difficult. A fusion or achieving the arthrodesis is delayed, and sometimes you may need a second attempt to do the bone grafting. And additional bracing is needed to protect the instrumentation. Pediatric cox spine, the biggest problem after successful treatment of the cox spine is development of the kyphotic or kyphoscoliotic deformity. As you can see in the images, the child at the age of 5 years, it was a straight one, and at the age of 10 years, we have found that it is a big deformity, and patient also has a neurologic deficit with that. The cause of the deformity is very clear. It is the anterior vertebrae which are not growing, whereas the posterior elements, they keep growing, and so there is a stretching of the cord. And so the patient is, in spite of being an angle maybe same, but at the same time, because of stretching of the cord, patient will develop a neurologic deficit. So let us find out how do we manage all these patients with the deformity or the heel spine and with the trouble. So if patient has a kyphosis with no deficit, either you accept the kyphosis, which happens quite often in our country, or sometimes the child, especially the female child, at the age of 16 or 18, they want to get a cosmetic correction, and therefore patient can go for the cosmetic correction. But at the same time, the amount of the risk involved must be explained well to the patient. With the kyphosis with the neural deficit, it's a big trouble. Here, you can do only decompression without changing any angle of the kyphosis, or you can do a decompression with a correction of the deformity. Now, let's have two examples. Now, this is a kyphotic deformity with a cord compression. Patient is 13-year-old male patient presented with a kyphotic deformity with progressive neurologic deficit. Now, this is a myelogram done that time. This is a quite a old images. That time MRI was not so easily available also. So this is what was done. The myelogram was done and showed a block at the level of angular deformity. What we did is we went ahead with the anterolateral decompression, which is shown as in a picture where the 3 to 4 ribs are removed and reach to the kyphotic area or internal gibbus, excise the internal gibbus and relieve the cord compression. Now this is only to relieve the cord compression. Here the angle of the deformity does not change. But because it is a fused spine, it is otherwise also stable in spite of doing an internal gibbectomy. So this is a post-op myelogram what we have, which you can see the free flow of a dye. At the same time, the patient is without any deficit, walking tall. Now this is an example of a correction of the deformity. This is a 7-year-old female bought by parents due to the concern of deformity noticed 2 years back with deficit, and it was a progressive. That was the angle 85 degree, and here definitely we need to do something because you can't accept the deformity. Definitely not because, especially because there is a cord compression and neurologic deficit. We got a CT scan done and found out the angle. It was 7, 8, 9, but 10, 11, 12. 3 vertebrae were completely destroyed and forming the internal gibbus. There is a pre-op MRI showing the cord compression at places. What we did the pedicular screw pass proximal and distal to the deformity. After that, we had put a temporary stabilization rod and we started excising the internal gibbus. On either side, the posterior elements were removed, and then from the just side of the cord, we started excising the internal gibbus. Here you can see the internal gibbus, which is almost removed. A complete space is available under the cord and nothing is compressing on the cord. This is how it confirms it. Now here we wanted to enlarge or lengthen the anterior column, but at the same time we wanted to compress the posterior column and shorten the posterior column. So anterior distraction or anterior opening and posterior shortening, that is how the procedure goes. This is what was done. The cage was put in a spacer and posteriorly it was compressed, and this was a post-operative picture where we could get a correction of 40 degree. We did not try desperately to get a more and more correction because that can be a hazardous to the patient, and therefore whatever correction we got very easily and acceptable, we accepted that. This is a patient after the 6-month post-op, and what we found is deformity, whatever the 40 degree was immediate post-op, that is well maintained. This is the patient with the bracing, standing and walking, and this is a difference in the curve of a sagittal. So take a message from here. Pediatric cox spine is different from the adult cox spine, and don't treat as the same. Conservative treatment works very well in a pediatric age group. Fixation whenever needed is difficult. Interbody fusion is delayed. You have to be very careful for that. A kyphotic deformity with or without deficit is the end result of most of the childhood tuberculous spine. Deformity correction, decompression always at a high risk, and therefore the prevention of formation of such deformity is one of the best treatment for the pediatric age group. Thank you for your kind attention.